So the question we have is exactly the one our patient poses us. What is the main cause of MI? And we have 6 answers so far: genetics, thrombosis, socioeconomic status, lifestyle, climate, or non-compliance to treatments. So we will see later on if the speakers will have changed your opinion about which of these factors is important.
Thank you for the opportunity to be here. I will not make any advocacy for this hypothesis that you are mentioning. I will not be defending the genetic factors, but just giving a brief introduction about the problem, which is, I think, a complicated problem. Here my disclosure. And so, how do we start with? There have been more than 160 loci that were identified and linked to the risk of coronary artery disease. And this explains about 30 to 40% of the heritability of coronary artery disease. And I think, most importantly, an estimation for the accounting for coronary artery disease tell us that this might explain 40% of all coronary artery disease cases that we see. Half of these loci, that's interesting, are associated with a range of other disease or other condition, sick condition. And among these 14 single nucleotide polymorphisms are specifically associated with an elevated risk of myocardial infarction. So this is the situation that we have at the moment. Of course, atherosclerosis, as we see, has an estimated heritability of 50 to 60%. And the role of genetic factor is to have an action which might be directly or indirectly, that means through an impact on the traditional risk factors, and both of these type of action may contribute to the manifestation of coronary artery disease. But, and this is important for your question at the beginning, when we talk to our patient, I think this is a very important argument to reinforce, is the premature cardiovascular disease in at least one parent is associated with a doubling of risk in a middle-aged man and a 70%, so even more, a little less, sorry, in increase in women. So familiarity, the family history, and we heard this morning reinforcing the need for a very careful anamnestic contact with the patient, and his familiar history is very, very important. And more than 2/3 of men who experience coronary artery disease despite low risk factor profile, meaning very well controlled traditional risk factor, have a positive parental history when we look for it carefully. So this is, I think, important even for a practical way of addressing our patient. And this is the concept that has been already emerging in the discussion of this afternoon, a very important and probably innovative concept that it's really important is the time of exposure to LDL and to cholesterol LDL in this analysis that you have seen before. Basically, it tells us that for the same level of genetically determined LDL or pharmacologically achieved LDL, what is really important is the exposure. So for people who are genetically, that means from their birth, exposed to low level of LDL throughout their life, the proportional reduction of coronary artery disease is extremely much higher than for the same level of LDL, but achieved in middle age or at the time the patient is experiencing a cardiovascular event. And this is, I think, a very important concept. So in summary, there are more than 160 genes that are associated with coronary artery disease, and 14 of them are specifically linked to an increased risk of myocardial infarction. Definitely, atherosclerosis has an irritability that can be estimated in 50 to 60%. And this is the result of a collective effect of genetic factors, epigenetics, and the development of atherosclerosis, and therefore its complication. And as we have seen, genetically lower LDL very substantially reduces the risk of coronary artery disease, and there is a log linear association between genetically and pharmacologically mediated lower LDL and the risk of coronary artery disease.
So this is my disclosures. So, as I've just told you, so presence of thrombosis inside the myocard and coronary arteries is very often in patients with acute coronary syndrome, no matter what was the primary cause. For sure, in most or majority of patients, the primary cause is the rupture of unstable plaque. But it can be spontaneous dissection, it can be traumatic dissection, and it can be unclear. So, but thrombosis almost in all cases in all patients with acute MI. So how does it look like? This picture shows you some examples from our lab using the optical coherence tomography. On the left side is a white thrombus. So because the thrombus starts to be formed by platelets, and platelets allow light go through, so we can see all structure, all thrombi located in coronary arteries. And then, after the fibrin is composed, it fixes the erythrocytes, the red blood cells, and form the red thrombi, and doesn't allow to light go through, so that's why we can't see after the thrombi. And in the right panel is a young guy presented with a huge acute MI, with huge thrombi in the left main and proximal LAD. We did nothing, we just put integral in, and the coronary artery was clear. And the second day, we just performed the OCT because the coronary angio was completely normal. So that's why we choose the OCT. And in the bottom of the picture, you can see the plaque with erosion in both sides. So, and this was probably reason why the thrombus formed there. We have roughly 200 patients below 45 years of age who suffered from myocardial infarction. And we still look if we can differentiate any risk factor why such young people suffer from myocardial infarction. And we have surprising answer. We haven't found nothing. Okay. So this is something interesting, because we check the genes, we check some procoagulation factors, and whatever you can realize, it can be reason for this, but still the answer is 0. So in small part or small proportion of patient, thrombosis is a dominant pathophysiology mechanism for occlusion of coronary artery, and the substrate for thrombus formation can be surprisingly small. It can be tiny dissection. We have one guy after boxing game, he suffered from chest pain, but he thought, okay, I lost my game, so this is probably trauma, and it was a spontaneous dissection of left domain and thrombus suppresses on this dissection. But the majority cases of this unstable plaque rupture and thrombus formation. And instead of the summary, this is a part of the guidelines. And if you check each guidelines for acute coronary syndrome, first line is antithrombotic therapy. So antiaggregation therapy, anticoagulation therapy. So these guidelines confirm my statement that the thrombosis is the most important pathophysiology mechanism of acute coronary syndrome. Thank you.
So I hope I will capture your heart, clean your heart, and avoid heart attacks with this next presentation. My presentation is very easy. There are 9 million premature deaths avoidable through pollution, which is 3 times as many as the total sum of AIDS, tuberculosis, and malaria, and 15 times as many as any war or any violent deaths around the planet. And we've known this since 2015. Let's go. I've only got about 4 minutes to go through the slides. My disclosures, that's fine. We've known David Newby's position paper in the ESC since 2015, and many of you will be co-authors to this. Many of you will have participated in the evidence base, the observational registries, the theories, and some of the experimentations. So I actually owe all this work to these colleagues of mine that have actually brilliantly coincided this paper that has not yet become a guidance, but luckily in 2019, thank you so much, in the chronic coronary syndromes guidelines, environmental factors actually tell us that if you've recently had an acute coronary syndrome, you must avoid highly polluted areas and you must avoid loud areas. So you have to go away from city conferences and go to the seaside like Barcelona quite regularly, particularly if you're at risk of an acute coronary syndrome. And I think air purifiers and masks are actually in that guidance, and I'm so proud of that guidance for having that in there. So I'm delighted with that. And actually, what are the mechanisms? Let's go through the science. So cold, we know, causes vasoconstriction, causes diuresis, causes the HTT to go up, platelet activation, and actually blood pressure to go up. We know this. And so that is quite common. And you see here very beautifully that if you get influenza, a viral infection, or pneumonia as a bacterial infection, this will not increase your heart attack risk by 40%. We're talking about 300% with the flu virus and 600% for up to a month with influenza and pneumonia that causes sepsis for over a month. New England Journal actually released these papers. Please check my references. They're highlighted in red to show you the caliber of all of these references. We're talking about a 600% increase in the risk of a heart attack a month after a bad pneumonia. And you can see across many years, across England and Hong Kong, these spikes in temporal monthly rates of influenza absolutely married by heart attack deaths. Here you will see a beautiful study on many studies on 100,000 patients showing you that at the point of a heart attack, if your temperature, environmental temperature, had been 10 degrees higher, even adjusted for sex, pollution, air quality, etc., you would have had 10% less chance of a heart attack within 1 to 5 days. We're not talking about statins of 2% absolute risk reduction at 4 years. We're talking about 4 days, a 10% reduction of myocardial infarction. These are spectacularly incredible. And Gitana, you've asked us, really, what causes in young people heart attacks? Well, actually, it's smog. We know this as experts in London because in 1952, the 5-day smog led to 9,000 counted deaths in 5 days, predominantly due to cardiovascular and respiratory deaths and some road traffic accidents. And actually, we created the Clean Air Act of 1955 and then found out that this was due to microparticles. Microparticles are amongst the most powerful pulmonary stimuli, get all the way into your alveoli and bronchioles and cause cardiovascular strain through hypoxia, oxidation. So it's very straightforward. The science is there. You may not believe me, but actually let's go through real associations of heart attacks in Germany. This is for you, Ulrich. Actually, when do you in your history ask about pollution exposure? And I want you to do that from now on, because actually when you get a young patient with a heart attack, you'll guarantee that they've been stuck in a traffic jam. It'll be a taxi driver, for example, a lorry driver. They'll have been stuck in a traffic jam for the last few hours. And these particulates, within 2 hours, will increase your risk by 24% of a myocardial infarction, and within 1 day of 60%. So genetics of 40%, well, this is 60% within 1 day of exposure to bad air traffic. How do these things work? We will actually be able to track even more. I want you, all of you in your mobile phones, to put in the 3 words, air, quality, and world. And you will come to websites called wacky.information. So please do that while we're talking. Look up the air quality in Barcelona versus Delhi, and you'll see that these tracking stations are actually seeing how many black carbon microparticles are in the air that you're surrounding and sitting in and going through, and these wearables will actually superimpose in the future strokes, heart attacks, and cancers, and you'll see an entire correlation. But that's still association. So how about this? This is a really scary experiment by David Newby, Nick Mills, and his team. We took normal, healthy medical students and doctors and actually put air-filtered petrol fumes through them, and you can see immediate increases in the heart rate and immediate drops in their ST segments. We are causing ischemia, and diesel is even worse. So that is ST segment movement for VJ, particularly, to say we're going to cause these ischemic episodes through bad traffic and black carbon. Air pollution has now, as I've said to you, in 2015, become representative for for 16% of all deaths and has replaced poor diet as the third commonest cause of climactic heart attack. And there is hope. In Scotland, when we introduced the No Smoking Act in public areas, there was an immediate drop in strokes and heart attacks within the first month of March 2006. When the act came that you could not smoke, there was a 20 to 30% drop, but human beings found another way to increase strokes and heart attacks after that first year, called vaping and other things. But there is hope. We can treat, we can prevent, we can protect your heart, and I'd like to thank the sponsors and the faculty for allowing me to remind you that climate is the only most important factor that will cause heart attacks that you can prevent. Go back to the villages, go and live like our grandfathers, 85 years old, picking grapes and figs and olives, and actually taking oranges and lemons, and actually learn to get away from the cities for your heart, for your life, and for your work. Thank you very much.
The potential role of socioeconomic status in the determination of myocardial infarction, or more in general, of cardiovascular diseases, I would use some data derived from the PURE study that was conducted very recently, presented at the last Congress of the European Congress of Cardiology. These are my disclosure and the disclosure of the institution for which I work. And there are some interesting data in this study, in the sense that this study confirms that the death for cardiovascular diseases are the most frequent causes of death overall in the world. But what is really very interesting is that it seems that recently in high-income countries, the most important cause of death is cancer and no more cardiovascular disease, while in the middle-income countries and the low-income countries, cardiovascular diseases remain the most important cause of death. This could be due to some changes in lifestyle, to probably good treatments and more adherence to treatment. Also, smoke-free legislation probably contributed to this reduction, but probably we are delaying the occurrence of cardiovascular diseases, and there is more time for cancer to occur. So these authors also put in relationship the gross domestic product of the different countries participating in the study and the ratio between deaths from cardiovascular causes and deaths from cancer. And as you can see, there is a clear relationship between the gross domestic product and the ratio between cardiovascular disease and cancer. Finally, the same authors did a very interesting evaluation, in my opinion, that can explain also which is the main reason. They did this kind of analysis, which is the population attributed fraction of the different potential factors predisposing to cardiovascular diseases. And as you can see, there are the usual traditional risk factors, such as hypertension, high level of non-HDL cholesterol, tobacco smoking, obesity, diabetes mellitus, low level of physical activity. But in evidence, there are also some factors that can be attributed to socioeconomic factors, such as household pollution, and this is in line with the previous presentation, a poor diet, low education, depression, and an excess use of alcohol. Putting together all this kind of information, you can say that 70% of the attributable fraction for cardiovascular diseases are related to the traditional risk factor, but quite a high rate, around 30%, could be attributed to socioeconomic factors.
Yes, I'm actually happy to take this topic, and I'm going to address you as physicians. genetics are important, but it's not so easy to change the genetic predisposition of a patient in front of you. It's also not so easy to fundamentally change the social, economic contribution or the pollution at this moment. And I would like to argue that indeed one of the preventable and addressable components that cause an MI is non-compliance. Now, is it frequent? Yes. Up to every third drug that has been shown in randomized controlled trials to prevent myocardial infarction is not taken by our patients as prescribed by the doctor. Is this important? Yes. In addition to causing a lot of cost, it has been calculated that 9% of cardiovascular deaths, so this is not only myocardial infarction, I'm talking about counting dead bodies, is attributed to poor adherence. And just an example for statins, this is also true for other drugs. You can see that both in primary and in secondary prevention, the number of days, the percentage of days where statin is taken is directly correlated with, again, death, survival. I'm not only talking about myocardial infarction. Now, poor medication adherence has many causes. It's a complex issue. It would be a separate lecture. Just one thing I would like to point out, that is the role of media. And you can see here from the Sunday Express and the Daily Express a collection of headlines reporting both negative and positive news stories. And I think this exemplifies, this Borge Nordesgaard collected these, and I think it exemplifies that the purpose of a journalist is to have newspapers sold, clicks on the homepage, and views on a TV show. It is not necessarily to report something that is true. And since many people take a stand, we have to understand that we will have to live with positive and negative news stories. This is not something curable or preventable. Now, is this important? Do we all in this room have to take care of this? Yes. This is an analysis from Copenhagen where different databases could be combined, and Borge Nordesgaard and his group assessed the effect of negative and positive nationwide news stories on persistence of statin. This is only statin, and you can see that there's a significant and quantitatively relevant effect of a negative and positive news story. And now this is really the punchline of this paper that I highly recommend you to read. This is, in fact, directly related with myocardial infarction. So a negative story about statins and cholesterol is here shown to cause myocardial infarction. And this is just one component of adherence. Now, last point, it is something addressable. It is not only a problem, it's also an opportunity. For example, this was a heart failure study. Working together with pharmacies, medication adherence can be significantly improved. And from the perspective of our meeting here in Barcelona, I think a major advantage of the PCSK9 injectables is that we have a very nice, and we have excellent data on this, that PCSK9 antibodies guarantee medication adherence and are, in this case, have a significant advantage compared to oral therapy. Thank you.
Now, Professor Mach will convince us that actually it's mostly lifestyle that increases our risk. So, please.
Yes, thank you, Gaetano. It's all about lifestyles. We all know that. I mean, if you look at this, you cannot change age, but lifestyle will implicate hypertension, lipids, obesity, diabetes, smoking, as well as sedentarity. So basically, let's be pessimistic. 80% of acute heart attacks are predictable. And this is our patient. This is my patient, you know. Quite blinded, needs to be close to the TV, but whatever. So there is primary, secondary prevention, and lifestyle is what we call now primordial prevention. And this is for everybody, for you, for me, as you will see in a minute. This is a study from Sweden. They look at 20,000 men, and they ask for 10 years for these men to do a couple of things, to have a good diet, low-risk diet, to consume some alcohol, to stop smoking if they smoke, to do physical activity, and to try to keep a low abdominal obesity, adiposity. And look at this, after 10 years, if these men can have either 1, 2, 3, 4, or 5 of what we call now a low risk factor, they will be protected by 80%. You will see in my last slide. What we did in Geneva for normal person, I was in this study, the Geneva Stair study. Easy to do. 3 months without using the elevators. I work in the 6th floor. You're not going to a coffee each hours because you have to take the stairs. For 3 months, we did not use elevators. This was just 90 normal individuals working in the Geneva University Hospital. My body weight was normal, but was lowered. My BMI was normal, but was lowered. My blood pressure, my lipid, everything goes to the green. Then, to answer your question to the patients, then we said, okay, stop and do what you do normally. And we all press again the button to go to the elevator. So everything goes back to less green or even purple for some of us. So the conclusion is important here. Encouraging stairs use at work. This is lifestyle at work, not asking you to go to the gym at 7 p.m., you'll be fine. No. Encouraging stair use at work is effective for improving fitness and lowering cardiovascular risk factor. If you look here, on the left part, you have lifestyle, physical activity, no smoking, alcohol, healthy diet. This will improve all what we know about modifiable risk factors, and thus will possibly reduce by 80% the risk of future myocardial infarction. And most of the place should be taken by physical activity. It may not reduce as much, but this is what our patients are not doing daily normally. So lifestyle, if you want to somehow fix the heart or not going to a bad or damaged heart, obviously this is less stress. Nice or a good diet, maybe an Italian diet. I'm trying to get your vote. And doing a normal lifestyle, and prevention should start as early as possible. Thank you for your attention.
My patients ask that all the time. Why did I get the heart attack, doctor? So I do have answers for them. So to respond to that question, all of the above, everything that we have heard so far. And I think everybody has really summarized the risk factors that causes a heart attack. And these are some of the pictures that really helped us understand the pathophysiology of plaque rupture and atherosclerosis by a very renowned British pathologist from London, who really opened the eyes of what's happening in the coronary arteries. You can see the top left-hand panel of a stable plaque, and you can see all the LDL sitting around the coronary arteries instead of circulating in the bloodstream. And when the covering of that plaque, the atheroma, gets thinner, you get an unstable plaque. And if that's when that ruptures, you have the volcano erupting and giving rise to plaque rupture and acute myocardial infarction, and patient ends up with the ST elevation MI, and they come to us in the cath lab and we try and fix that. So last year about this time, I was asked to be on one of our television channels. They asked me to provide an answer why the part of your country, northeast of England, is showing up as red for heart disease. And this is the map showing the age standard. The darker the color, the higher the death rate. So you can see Scotland, which is where at the top, and the northeast of England has got the higher rate of, so a lot of death happening due to cardiovascular disease in this region. And one of the main factors, as we heard earlier on, I think Professor Aldo Maggioni showed, the socioeconomic factors. And a lot of people live below the average earning wages in the UK. So, for example, Northeast people live 16 years less than if you live in Kensington, which is probably where Amit is from, Chelsea and Kensington. So that's really shocking, and the cause of death in these people is due to cardiovascular causes. And this is that I showed you for the figure that I showed you is for previously was for the United Kingdom, but look at Europe, and many of you are representing these regions. Again, the darker the color, the higher the number of people dying of ischemic heart disease. And in my previous presentation, staggering 45% of patients are dying of heart disease. And we have, most of us physician cardiologists have spent our life in treating these patients, but we're not quite there. I'm exhausted waking up in the middle of the night and fixing these arteries, and yet so many of our patients are dying. Smoking. And this is really, highly, you can see again, Eastern Europe has a higher incidence of smoking, and for women there's a little bit of a shift to the Western Europe, and I'm really shocked, when I fix STEMI arteries and see them 6 months, a year later, and you can smell when they walk into the clinic of cigarettes. And there's no point, as I mentioned already, giving all the treatments, and yet it's like pouring petrol over a burning fire, really. And it's really absolutely vital that this gets taken care of. And we already heard about physical activity. I think you presented an elegant study from Switzerland. And this is the European statistics. Again, people from the Eastern Europe, both men and women, physical activity is so much lower. And again, that translates into the number of cardiovascular deaths that's sustained in these regions. And one of when I was asked on the television, what do you advise? Instead of taking the bus, start walking, daily practice, take the stairs, and that goes a long way in affecting a number of parameters. And again, I say it's like taking 5 tablets. Physical activity helps your platelets, it helps your cholesterol, it helps pretty much everything, your brain. So here we are, this is 2017 statistics, and there's still a lot more work to be done. Blood pressure, again, we know blood pressure causes heart attacks, and see how many people still are undertreated. And again, in the Western Europe, the prevalence of hypertension is much higher. And these are the areas where we see a higher burden of cardiovascular disease. Cholesterol, that's the number one diet in the UK, fish and chips. It might be different, as perhaps all of us will need to learn about the Mediterranean diet. And again, food plays, you can see the darker areas. Prevalence of raised cholesterol, United Kingdom, Spain. And it's very surprising to see the Eastern Europe is the prevalence is much less than the Western world. Maybe that's down to the rich food that we consume. And BMI, again, in the Eastern Europe is much higher, and that might be a reflection of reduced physical activity as well. Diabetes. We've talked quite a lot about physical activity. Diabetes is something, and again, that's something when for the first time they come with an event, you do a BM. It's mandatory to do a BM on admission, and you're surprised that their cholesterol BM is 17 or 18. They might have had glucose elevated for a long time, but never been tested, and it's a major risk factor for cardiovascular disease. And Amit very elegantly pointed out the impact of pollution and environment directly on cardiovascular disease. And this was the headlines a few days ago on BBC about Delhi. The air pollution level is becoming unbearable, not just in Delhi, everywhere we live this is the case. And it might take over other risk factors in terms of increasing the cardiovascular events in our patients. And again, as I mentioned, not just always it's the atherosclerotic, we also need to think about the other uncommon causes of STEMI as well when answering the questions to patient. That was the patient with the preponderance to thrombosis and this is aortic dissection, secondary to hypertension, again a risk factor. Instead of developing a proper atherosclerotic event, that patient had an aortic dissection as a consequence of hypertension. And all of these cost a lot of money, and a lot of these can just be treated with simple measures, looking after our environment, doing exercise, eating healthy. And yeah, we've come a long way, but we still have a long way to go in the management of cardiovascular disease. So thank you very much.
But before that, we have to change, see who has changed your opinion more on the cause. And please be now ready to vote. And what do you believe is now the cause of MI? Genetics, thrombotics, socioeconomic status, lifestyle, climate, non-compliance to treatment. We have also all of the above as potential answer. So this is really, really good. Now, I think, Baha, you have made a great work on climate. I think we need to make an applause to Vijay, who convinced us that all of the above